Please welcome Dr. Chauhan.
Thank you, Bob. Good morning, everybody. So that was a wonderful talk, Dr. Chandana, and I'm really happy to know that your patients here have access to some of the cutting-edge therapies. And trust me, it's not easy to have access to good phase 1 programs, so I'm very happy for the patient community here. Also, thank you, Marianne and Bob, for hosting a meeting here. I cannot emphasize how important it is to advocate for yourself. And I always feel that my neuroendocrine tumor patients are so well educated, informed, and that really helps everybody involved in their care, from nurses to social workers to dietitians to the doctors, to deliver better care. And so fantastic. Thanks for joining us. My name is Chauhan. I do neuroendocrine tumors and high-grade neuroendocrine carcinoma management at Markey Cancer Center. It's one of the NCAN designated cancer centers in Kentucky. Some of the other hats that I wear are phase 1 drug development. So these are very novel or first-in-human clinical trials and trying to develop new treatments. We've come a long way because of giants in our field like Dr. Howe and others, but we still have a long way to go, right, till we achieve cure one day, hopefully. And that would come through research and clinical trials and developing new therapies, and that's what I spend a lot of time doing, and that was one of the reasons I decided to come to the US. Wonderful research opportunities. And lastly, we have also felt a need that for pediatric neuroendocrine tumors. Unfortunately, it's rare, but it does happen in our pediatric patient population. So we've developed a pediatric neuroendocrine tumor program and a clinical trial program for them, and that's a very recent. So today, I would be talking about, these are some of my disclosures. I would be talking about carcinoid syndrome. You've probably heard about it. So we will talk a little bit about what is carcinoid syndrome, what causes it, and more importantly, why do we need to recognize this early, and what kind of complications that can happen so that we can prevent some of those. Now, the root cause of this syndrome is, carcinoid neuroendocrine tumors, as Dr. Chandana mentioned, can either be classified as functional neuroendocrine tumors or non-functional. What does that mean? So if these tumors secrete certain hormones or chemicals which can give you symptoms, these could be flushing or this diarrhea or wheezing or joint achiness or fatigue. Depending on what hormone the tumor is secreting, they are considered functional neuroendocrine tumors. Fortunately, most of the neuroendocrine tumor patients don't have functional NATs. Okay? Some studies quote up to maybe 20, maybe 30%, but still it is a relatively smaller subset of patient population. But the ones which do have those functional neuroendocrine tumors, they tend to have a lot of quality of life issues with bad diarrhea or flushing or fatigue. So it's a really important condition for both the patients as well as the doctors who manages those. The other bigger category is non-functional neuroendocrine tumors, where the problem is really happening because of the tumor growth and the mass effect, okay? So the tumor growing in the bones or the liver or lymph nodes, right? My talk is specifically focused on functional neuroendocrine tumor, and out of the functional neuroendocrine tumor, specifically serotonin-related functional neuroendocrine tumor, because these functional neuroendocrine tumors can be functional because of X number of hormones, right? Some of these hormones we haven't even yet discovered. There's so many. However, by far, the commonest hormone which is secreted by these tumors is serotonin, the commonest. But some others would be kallikrein, prostaglandins, histamine, and there are so many which we haven't even yet discovered. But those are fortunately very, very minority. So let's talk a little bit about the commonest one, the serotonin, right? We have known about serotonin for good 95 years now. And a lot of really smart scientists were able to first detect this particular chemical which regulates our gut, and then later people joined the dots, and eventually in 1952 we kind of realized this chemical called entramine and serotonin is one and same thing. But what I really want to summarize is this has been work in progress for close to 100 years now, okay? And we really build upon our understanding and how we leverage that understanding into therapies on a lot of really cool work been done from very smart people over decades. So serotonin is a hormone which is produced normally in our body. Let's talk a little bit of normal first so that we can then flip to the abnormal. And where does it come from? Our body manufactures it from amino acids. So basically anything we eat protein with tryptophan, and that gets converted into serotonin, which is also known as 5-hydroxytryptamine, 5-HT, same thing, okay? And there's a two-step process. We will come to that in a second. And where all is it found in our body? Primarily in our gut, okay? That's why when we have the problem related to serotonin, we'll have a lot of gut issues. We'll talk about that in a second. But even in normal state, all of us make certain degree of serotonin in our body, 90% in the gut, a little bit in platelets, and very little bit in the brain. It's a neurotransmitter. So you've probably heard about association of serotonin and mood and depression and SSRIs, those drugs, right? So very little bit of serotonin is really needed in our CNS or the brain tissue for mood regulation. And it helps us kind of, with the mood regulations, etc. Now, once these serotonin is manufactured in endocrine cells and other areas of the body, it is then stored in some sort of sacs called granules and then released whenever it's needed. Okay? The good thing about the serotonin which is secreted or manufactured in the brain, it usually sticks around in the brain. It doesn't cross because our brain's covered by what's called blood-brain barrier. Okay? So very common question in the patient conferences is, hey doc, does having too much of serotonin cause the mood issues, or taking the medications which can increase the serotonin give worsening Carcinoid syndrome? Fortunately, we have not seen that happen, and probably it's because the serotonin which is involved in the mood regulation is very different entity. It's protected in a different compartment in the brain. So perhaps blood-brain barrier has something to do with that. Let's focus a little bit on the gut. And we are still on the physiological or the normal end of things, right? So some of the cells you see here labeled as EC cells, enterochromaffin cells, that's normal. All of us have it. And these cells manufacture serotonin through the diet. Tryptophan gets converted to serotonin. And when we eat, we need a little bit of serotonin for digestion so that our gut can move, can secrete certain gastric or intestinal juices. So all of this is an interplay of serotonin plus various other chemicals. It is just part of the puzzle, okay? In addition to enterochromaffin cells, it is also a neurotransmitter, as I told you, right? So certain nerve cells, so neurons or nerve cells are not only in brain, but they also innervate a lot of our body. That's how our brain and autonomic nervous system control our body, right? So if I eat something, my gut needs to know that, okay, the stuff needs to get churned, get broken down, and then move forward, right? We call that moving forward process peristalsis, right? Sorry about the physiology lecture. You guys probably didn't think about that, right? So we'll keep it very short, okay? But this particular hormone, serotonin, as you can see here, is the key messenger. How does a neuron interact with the muscle, right? They don't have a language. Serotonin is the language. So as soon as we eat, these neurons would then release certain chemicals, one of them being serotonin, and that serotonin would act on the gut and then move the peristalsis and the other digestive process. All of us do that at certain level, okay? So this is all normal. Now let's talk about the abnormal. So they say everything in excess is poison, right? Even too much of water is not good. So same thing with serotonin. Neuroendocrine tumors, as I mentioned, especially functional neuroendocrine tumors, they tend to make excessive amount of serotonin. This whole pathway is revved up. And when you make tons and tons of serotonin, all these normal physiological processes go haywire, right? So they're being calibrated normally to do the checks and balances, but when you have a lot of serotonin load, that will give rise to a lot of problems. As you can see here, tryptophan, which comes from our diet, get converted into serotonin, which is 5-hydroxytryptamine, by two-step process, and then it gets stored in these granules that we talked about, right? And then whenever certain triggers happen, like stress, some people, that could be certain cheeses, for some people could be red wine, everybody's very different. These granules then release the serotonin into blood and gives all these terrible symptoms, right? So it's not a constant process, it's a sporadic. So that's why somebody who flushes or has diarrhea, they're not having it constantly, but it comes in the spurts, right? And that's because of that. It gets stored, right? So elevated serotonin primarily gives two major issues. One is carcinoid syndrome, and other one is also there is a thought process that it affects tumor growth and could be potentially bad for disease as well. So this diagram here shows the clinical manifestations of carcinoid syndrome. Carcinoid syndrome is not just diarrhea or flushing, okay? However, diarrhea and flushing are the two commonest ways that it manifests. You know, see the prevalence of carcinoid syndrome, the biggest is flushing, diarrhea, but there are so many other symptoms that we often don't talk about, right? Cramps, dilated blood vessels, edema, swelling of legs, arms, wheezing. Wheezing is the noisy breathing, like asthma-like breathing, right? So there are a lot of other things, fatigue, that is a clinical manifestation of carcinoid syndrome. But by far, diarrhea is the most quality of life limiting syndrome, symptom of this particular syndrome. And that's really important for us to control that. Too much of diarrhea, loss of nutrition, weight loss, cachexia, not good. All right. So that was basically kind of sort of summarize that. Besides these terrible symptoms, carcinoid syndrome or elevated serotonin can cause some terrible complication. And it's very important for us to be educated about those so that we can prevent them. And prevention is a lot better than treating these because the treatment for these conditions is not very optimal. So, and what are those three conditions that I often alert my patients about? One is carcinoid heart disease. The other one is mesenteric fibrosis. And the third one is pulmonary artery hypertension. Usually the carcinoid heart disease and pulmonary artery hypertensions are sort of intermixed. There's some degree of both. So we'll talk about both of them in one go. So what is carcinoid heart disease? When we have too much serotonin in the body, and these tumors are producing a lot of serotonin, all this serotonin can actually directly impact the heart because all this serotonin in the blood literally eats up, a very simplistic way, the valves in the heart. So it is very corrosive or fibrotic effect on the valves. The valves are literally destroyed. And this process happens pretty fast. So if somebody, a patient comes to me with carcinoid syndrome, neuroendocrine tumor diagnosis, and start having edema, leg swelling, shortness of breath, these are very classic congestive heart failure symptoms, especially the right-sided heart failure symptoms, then I automatically think about carcinoid heart disease. And that's why every functional neuroendocrine tumor patients in our clinic get a baseline echocardiogram. We really need to know where we are starting from. Has there been any damage done to heart already? And then we have to keep heart under surveillance. Now, fortunately, because of all these fantastic advancements and treatments, and recognition of this condition, the incidence of carcinoma heart disease have gone down. And it's very rare these days for us to see carcinoma heart disease patient. But that's a good thing because we are recognizing it sooner. We are preventing it from happening. Unfortunately, if it happens, it's very complex to manage. And you have to involve cardiology, cardiothoracic surgery, and medical oncology to kind of manage these, and our surgeons. Because it's a two-pronged problem, right? One is we have to lower the serotonin, and that's where our medical oncologists would start on certain medications. Our surgeons would help us debulk the tumor, lower the serotonin. But at the same time, we also have to manage the heart failure. And we have to get the cardiologists on board, change the valve, get them on medications for heart failure. But it is a complex process. It's always better to avoid this problem by recognizing it early, by not letting serotonin go very unregulated and uncontrolled. Another reason it's important is to recognize this situation is because we know from previous studies when you have very high level of serotonins, so 5-HIA is a breakdown product of serotonin. We collect that in the urine, 24-hour sample. So higher the serotonin, higher the 5-HIA. It's the same thing, okay? So as you can see here in the diagram, if you have 10 times, more than 10 times upper limit of 5-HIAA, the 5-year survival dips down from 83% to 50%, right? So that's not good. That tells you if somebody has an uncontrolled carcinoid syndrome, uncontrolled serotonin, these patients don't do well. So we really need to bring down serotonin, have it in control, not only for improving the symptoms, but to prevent some of these really bad complications like carcinoma heart disease, okay? However, I do caution you, these data is maybe a little bit dated. This comes from an era when there wasn't very prevalent use of lanreotide, sandostatin, and other modalities. So hopefully these outcome data in next iteration of these epidemiological studies would show improvement. But this is important to know when these fancy things were not there and you understand the natural history of disease, progression, and the biology of disease, if left untreated, patient can have poor outcomes. Moving forward, we touched upon if somebody does develop carcinoma heart disease, then what do we do? It's an urgent situation. We try to co-manage with cardiology, and you have to work on the heart failure and the valve problems. At the same time, the medical team, the oncology and surgical oncology teams try to lower the burden of serotonin with help of medications and certain other strategies like embolization or stage debulking in due time. The other important complication that I want to mention here, and that is a headache for not only the medical oncologists but even surgeons, is mesenteric fibrosis. So serotonin, elevated serotonin, has been implicated in causing fibrotic changes in a lot of tissue, one of those being mesentery. It is a soft tissue which attaches your bowel to your abdomen, and elevated serotonin can cause a lot of scarring. Fibrotic process is basically sort of scarring. And if you have a lot of scar tissue in the bowel, what can happen? Obstructions. So you can, if somebody presented to the hospital with obstruction, you have no other alternative. If it doesn't get relieved with conservative measures, you have to go in and operate. And then surgeries can itself cause certain fibrotic issues down the road. So it's a really bad vicious cycle. Ideally, you do not want to get in this trouble. Unfortunately, most of our treatments also don't work very well for mesenteric fibrosis. So recognizing this situation early, controlling the serotonin well in advance so that we don't get into these complications is the best way forward, rather than trying to manage it either surgically or medically when there's significant fibrosis has happened. And lastly, serotonin and role of serotonin in tumor growth. Now, there is some lab data. It's you got to take it with a little grain of salt. But there is some data to suggest that when there is elevated serotonin, it tends to promote tumor growth. But what does our clinical data suggest? Now, we don't have a lot of good quality prospective data to suggest that, that elevated serotonin causes tumor progression. However, some series would tell you patients who have lower serotonin do better, live longer, or have more disease stabilization. So it's an indirect correlation, right? Patients who have high serotonin tend to do worse, right? So all the more important for us to control serotonin, lower the serotonin, not only for symptom control, but seems patients do better as well and live longer. This is coming back to the flow chart, how serotonin is made. Just a quick recap: tryptophan, amino acid from our diet get converted into serotonin 5-hydroxytryptamine and then stored in the granules and released. When we understand the basic pathophysiology, that also gives us opportunity to fix the problem, right? And that's why so there are two problems here, right? One is manufacture of serotonin, and that gives us an opportunity to block that process. And we'll talk a little bit about a drug that does that. That is Zermello. The other opportunity we have here is these granules are there. What if there is a way to stop them from releasing out? As long as they stay in, no big issues, but when they are in the blood, that's when they give you symptoms, that's when they cause heart disease and mesenteric fibrosis and other things. So there are two drugs, lanreotide and sandostatin, which joins the somatostatin receptors and block the release of these granules, right? So this is how these drugs work. We always thought about, hey, these drugs work, my shot really helps me with carcinoid syndrome, right? But how do they work? This is a very simplistic way to show how they work. Let's talk a little bit about the first drug, the sandostatin or lanreotides, right, which is once a month shot. So we first understood that this class of drug called somatostatin analog really helped our neuroendocrine tumor patients. I was about 1 year old when this paper came out. This is 1986, right? Really cool, 84, sorry. Landmark paper, and at that time, we used to give short-acting somatostatin analog to control carcinoid flushing, diarrhea, and as you can see here, out of 24 patients treated, 19 showed benefit with flushing. 25 patients with diarrhea, 19 showed benefit. This was a game changer back in those days. The problem with this drug is it works well, but it's very short-acting. So somebody who's having multiple episode diarrhea and flushing, they have to keep injecting multiple times a day. It's fine for a day or two, but imagine living with a chronic disease for years. It gets pretty tiring fast, right? And from there was a big advancement in formulation of drugs where long-acting version of these drugs were formed, sandostatin being the first one, which was tested in this large study called PROMID study, followed by lanreotide, which was also studied in a randomized controlled trial called Clarinet study. These studies happened between 2000 and 2013. And now we have, because of all available to our patients, and honestly, these drugs form the backbone of the management for my neuroendocrine tumor patients. They have been amazing, very, very limited side effect profile comparatively to what I use for other cancers, chemotherapies, radiations, very well tolerated, and they really work. They not only work to help lower the serotonin and control syndrome, but also work to slow the tumor down. And how do we know that? The Clarinet study clearly showed the patients who were on lanreotide had longer disease stabilization, what we call progression-free survival. Okay? Now, moving forward, let's talk about the new kid on the block, the tellitrostat ethyl. This is an oral pill, and some of you who are on either sandostatin or lanreotide do realize that, okay, these drugs work great, but sometimes they don't work as well as they work at the beginning of the month, or they lose the effect, or despite working well, maybe bringing diarrhea down from 10 stools a day to 6, but 6 is still pretty high. Can we improve the syndrome control a little bit more? And this is where this particular drug was studied called Zermelo, and it blocks the conversion of tryptophan into serotonin. So that was the second pathway I was talking about, blocks the manufacturing process. And it complements somatostatin analogs, the lanreotide and sandostatin. This drug was studied in a large international study called Telestar study, and you can see patients who received the drug, 2 different doses, either 500 milligram of Zermelo or 250, they had big time reduction in their serotonin or urinary 5-HIAA as compared to the placebo, which was basically a sugar pill. This translated into improvement in diarrhea as well. So patients who were on Zermelo had lowering in the bowel movement. This is what we were trying to achieve as compared to those who weren't, okay? And this finally led to FDA approval for Zermelo in patients with carcinoid syndrome diarrhea refractory to somatostatin analog. So in summary, serotonin overproduction is a driver of carcinoid syndrome. We learned about carcinoid syndrome. I could not touch on every aspect of carcinoid syndrome, but the biggest one is the serotonin-led carcinoid syndrome, and we talked a little bit about it. Serotonin plays a very important role in some of the complications like heart disease and mesenteric fibrosis, pulmonary arterial hypertension. It's very, very important for you to flag your oncologist, hey doc, have I been monitored for carcinoid heart disease? Especially if you have elevated serotonin, if you have functional carcinoid heart syndrome, it's very important to flag them and kind of keep an eye on those things, okay? Serotonin has potential also on tumor growth, so another reason why you want it to not get out of hand. Patients who have better controlled serotonin or urine 5-HI, they tend to do better based on some of the historical data. And control of serotonin exposure is important to improve quality of life, prognosis of patient, and carcinoid syndrome. With that, I would like to conclude, but I would also like to give a small plug to a brand new study that is just recently launched and would be available at a lot of centers within the US and also outside the US. But we were the first site in the world to open it at Markey Cancer Center. And this drug is called paltusotine. It's an oral pill. Some of you might be on somatostatin analog for several months, several years, and some even several decades. And after a while, getting once a month shot, I know I hate needles. Some might like them, some might like the idea, okay, it's once a month, but other might want an alternative, something that can be taken as a pill. And there was a big need for an alternative for a shot, maybe a patch or maybe a pill. But there was not a whole lot drug development happening that, friends. I'm glad that somebody took that challenge, and paltusotine is an oral somatostatin receptor agonist, basically trying to lower the carcinoid syndrome, diarrhea, and flushing. And this study is going to treat about 30 patients to look if this pill works as well as sandostatin or lanreotide, or for that matter, even short-acting somatostatin analog. So very, very excited about this study because it gives one more option for our patients, and options are always good, right? With that, I'd like to thank everybody for their attention. We will take some questions later in Q&A. I think there is a small break now. Thank you, guys.